Hello and welcome to the SRHR podcast. I'm Solomon Serwanja. This podcast is in proud partnership with the Center for Health, Human Rights and Development, SRHR, which has been really working a lot on the subject of sexual reproductive health and rights. They have gone through litigation and have done amazing litigations. I remember the petition 16, which we'll perhaps speak to later. They have also been very strong on community involvement and dialogue. And today, we thought that we could have a conversation around something that in this country, people shy away to talk about. That's the subject of abortions that are happening in this country. Every single year, the government of Uganda allocates a significant budget to government hospitals for post-abortion care. But it's only important to also note that the members of parliament who know what is really happening in their communities have decided to put their heads under the ground, and every time this conversation comes up on the floor, they're all up against it. There are religious circles in this country that don't allow using of condoms or contraceptives for unmarried people, and so they're saying sex should be for procreation and not fun. The truth of the matter is people are having sex, and sometimes it's unprotected sex, and that eventually leads to pregnancies, some of which are unwanted, by the way, from young people to marrieds. There are marrieds actually who get pregnant and they want to terminate their pregnancies, but because of the legal and policy framework that surrounds that, oftentimes they don't get to go to get clinical safe abortions in the different hospitals. They are usually chased away, and what happens is that they go and try to seek, options elsewhere. And so we've had many go to back-end crude, spaces to have, this pregnancy terminated. Some of them go to witch doctors, others go to herbals, others use everything. I have been covering this story on abortion for quite a while, and I have a series that I did, and it's online. And I remember talking to different people, young people. I have talked to policymakers, I've talked to cultural and religious leaders, I have talked to members of parliament. Every time you raise this debate, it really leaves us divided. But what are the facts? The facts is that young people are having sex, and that young people are getting pregnant, and some of them don't want this pregnancy. But say no more, we traveled for kilometers away from the capital Kampala and went to Mbale. And so we had an interface with Fazila Nabuloli, who is a relative to a young woman who died, Sarah Namono, because she went to get access to a service that wasn't given, and she resorted to a crude way of terminating that pregnancy. I think it's only fair that we get to hear her story. Here is Fazila Nabulo, who now is taking care of the children of Sarah Namono, who died after committing a crude abortion. And she forms the statistic of the women who die annually as a result of crude abortions. Fazila Nabuloli from Bali.
Fazila mulimo gwange gwa bala oba dobi naye abaana bana kale okusooka kwenyini waliwo ekifo kye basookera kwange ngulu eyo kye twakuliramu katweyagala ng'omanya amaka nga kadde bakyaliwo naye kale sasa ge yajja kadde baffe ne batufaako ne tubanga kale ate nga tetweyagala bulungi ng'omanya okula nga tolina muzaddewo ngenda musaasaana buli omu n'akwata erirye
mukugana papa we wanyala papa we katonda weefuga
naye kale muganda waffe teyali mubi etubeererawo nnyo abazadde bagenze then n'atubeererangawo ng'atugumyayo we yatuuka siniyafu n'alaba ng'ate bimukalubiriza n'agamba bannange at least imwe mweyongereyoko naye ate wetwalaba ate nga yafunye omusajja n'abanga atuvuddeko tugamba ate mukulu waafe agenze olwofa abato n'afuna omusajja afuna omusajja n'abeera naye n'atuuka okufuna olubuto ne bafuna olubuto n'azaala omwana we oyo owokubiri bw'azaala owokubiri ng'omanya eby'omu maka nga weebiba ne bajja ne bayomba kaseera we kaatuuka ate musajja ng'ayagala kwefuulira ani omukazi ng'ayagala amutte kale musajja yalimu obwenzi bwalinga bungi omukazi nga waayogerako amuyisa bubi era olwavaawo alina mukwano gwe mu tawuni eyo bw'afuna mukwano gwe n'amugamba jjana tugende tukolenga ne bakola n'amufunirayoako omusajja ali eyo Teeso musajja Muteeso wafuna omusajja oyo Muteeso ne batuula paka oyamala okuzimuzaalamu naye abaana babiri naye n'alaba nga embeera emukaluubiriza nga mujja wa muli bubi mujja wa omukulu n'agamba si kaaki kanzire embaale najja n'abeerawo embaala eyo naye nga kataawo nga maze okusetolinga bulungi naye kale embeera kale yatuuka ekiseera nemukaluubiriramu natuuka ekiseera n'afuna omusajja afuna omusajja oyo kale naye ne babeerabeerawoko we batyo ng'omanya eby'omu bufumbo n'agamba nga sinaba kubeera naawe nekasooke nkole ka bizinesi akange n'atandikirawo mpola n'agamba muganda wange kyemba nkola kantunde nga ki mitwe gy'embuzi agamba kati kafuneyo omuki omubeezi afuna omubeezi we oyo ne babeerawo bazaalayo omwana kaana kakali kawala kati wamala okuzaala ng'omanyi omuntu n'agamba ali musajja ali kunkyankalanya kafuneko omuntu wabweru oyo anasobola akola ki kugumira ebizibu byange kuba ndaba ono tuzaadde naye omwana naye ndaba takola ki tampa buyambi bumala kati wabweru alaba ate nga amufunyisizza olubuto lugenda lukula ne luweza myezi 5 weyavaawo n'agamba munnange kangende gyeri omuntu wange nanyini lubuto ngende mugambe nti munaye lubuto lukuze ampe atandika okumpa obuyambi lunaku lwe lwatuuka ne yeesitula n'agenda weyagenda n'atuukayo n'amubuulira omusajja ate ye kye yakola nemugamba nti munange anti kati nsaba buyambi omusajja yayimugamba nti olubuto si lwange neyeekyanga kati weyeekyanga ng'omanya ebifo ebyaffe eby'abakazi namugamba lubuto si lwange olwosirabika lubuto lwa musajja mulala nekitamumalira nasalawo muganda wange olw'obusungu obungi yakomawo ewaka naye teyaŋŋamba kintu kyonna yagenda ali omukazi gwe tulina eyo yagenda n'amubuulirako ebizibu by'alina muganda naye nti tulina olubuto lwa myezi 5 naye onyamba ompaako magezi ki oba advice ki n'abuuza sisita wange ng'omanyi sisita wange yamugamba nange olutuuse kati musajja tali kumpa buyambi kangende ndugyemu yamutwala mu kafu ke bayita musoto wamutwala eyo n'atuukayo ne bamukolera ku ddagala ery'ekiddugavu kati wanywa bamugamba nti otuuka ewaka weebakemu kati ekyo tekyamumalira n'agamba kanga ateko ki eddagala ly'ekizungu n'agenda ate naye n'akola ki n'agaatako n'amira kati wamala okumira n'agamba kaneebakemuko kati weyayimuka ekintu ekyo kumbe kimaze dda okola ki okufuluma kati wekyafuluma n'afunamuko olungu bango n'agamba kankole ki kankisitule ngende nkisuuleyo kati abamulaba ne bajja ne bangamba naye nze nentakitwala kintu ekyamakulu ne ngamba kankite. Kati olweggulo nali ndi awo ntudde essaawa zaali 2. Ezaali ssaawa 2 nendaba ate musajja ajja mpita nagamba muganda wali kufiira mu ddwaliro nti kiki ati nedda jja ntugende gwe mwenyini weerabireko. We natuuka mu ddwaliro ne ntuukayo ne ndaba ate ng'embeera ekoze eki ekalubye nnyo. Ne neesitula ne ngamba engeri gye tutatalina ssente ate least kangende tuyiyeeko ku ssente. Musawo n'angamba nedda twagala emitwalo 3 first aid. Ne tukola ki ne tugenda tugula eddagala. Naye ng'omumanyi ebyabasawo n'angamba asooka oleete kanula aleetako kino oleeta kiri naye nga muganda wange ng'ali ku buliidinga nnyo. Tugamba kale tekirina buzibu ne batugamba ngenda mugula eddagala. We twagula eddagala teryatumalira we bityo we twatuuka awo kugenda kugula eddagala mbu banoonya misuwa ne gibula. We gyabula dakika zaayitawo mbale musawo n'atugamba nti ono tasi waakubona. Tugamba kweri ne ngamba nedda ne mpakana n'omusawo. Musawo n'angamba sisita wo si waakubona, sisita wo agenda afa. Ne mugamba nedda musawo at least gezaako n'onoonya wadde emisuwa ku kigere at least ogifune. Musawo n'angamba nedda muganda wo afudde.
Wow. That is the story of Fazila Nabuloli, who was a sister to the deceased Sarah Namono, who of course had a crude abortion when the pregnancy was 5 months old, used local herbs, and later on started to have, I think she did self-medication, and later on was pronounced dead in Mbale Hospital. These are real life stories of people who are seeking to terminate a pregnancy because they know they can't go to the health centers. They resort to other means. On this podcast, I have Dr. Lukomwa David, who is an obstetrician gynecologist at the Entebbe Regional Referral Hospital. He's also the member of the Association of Obstetricians and Gynecologists of Uganda. Also, I have with me Peter Echeru, who is the programs coordinator for Advocacy at the Center for Health, Human Rights and Development. I think it's... Dr. Lukomwa, let me start with you. You've just heard the story of Sarah Namono, and I'm sure these are stories that you encounter every day. You are always on the front line. What has been your experience?
Thank you, Solomon. I'm really sorry about the story of Sarah. May her soul rest in peace. But looking at that story, it gives me the whole account of what we face in the hospitals. Okay, right from domestic violence, you see there's an issue of poverty, there's an issue of lack of social support, and then there's an issue of lack of information and knowledge. Yeah, so first of all, let me try to highlight what an abortion is.
Yeah.
An abortion is termination of pregnancy before the time the baby is able to survive outside. In Uganda, we put that at 28 weeks or 7 months of pregnancy. So if a baby comes out of the uterus before 7 months of pregnancy, we call that an abortion. However, also what needs to be known is that not all the abortions that do occur actually induced. About 30 to 40% of those abortions are actually spontaneous. They happen on their own without the mother doing anything or taking any medicine to have the pregnancy terminated. So about 30 to 40% of the pregnancies are spontaneous. They happen on their own. Woman gets a pregnancy, she's okay with it, but out of the blue, maybe for some reason, or there's an infection, or the cervix is weak, it comes out. Okay? Yeah, and many times if you deal with that reason, she will carry the pregnancy. And then the other percentage are those abortions that are actually induced. Here there is a deliberate intention of either the mother or a health worker or any person. Something that they do to have the pregnancy terminated, and those are the ones that are actually causing us problems. Okay.
Wow.
Yeah. Although the spontaneous abortions and induced abortions can take on any of the complications like severe bleeding, infections, but they are more common in those which are induced, and it depends on how the abortion is actually induced. Okay. It can be done safely. That is, if it is done by someone who is qualified, say has the skills to perform the abortion. They know the instruments to use, appropriate instrument, and then the sanitary environment, okay, where they do the abortion. But many of them that come with complications actually done by unskilled people. They are done using weird equipment. We have seen girls who come to hospital with sticks in their private parts. Some have used wires.
Wow.
Okay? So they come with all sorts of things. And then also the environment also exposes them to a lot of infections. If it is done in a place which is not which is not of good sanitation, okay, they end up coming with very bad infections. A woman walks into hospital, and the moment she steps into the hospital like this, the whole environment starts smelling. You just know that this one is a septic abortion, an abortion that is complicated by infection, and many of them are actually draining pus, which is not good. So
Sepsis.
So it is something that we see on a daily, and we cannot take it lightly.
My goodness.
Yes.
Doc, you've encountered someone who has come with a stick or wires.
Very often.
Because many of these are young people who don't know what to do, actually. They're trying, I mean, at the tail end of it is they want this thing out. Sometimes they call it a thing. They want just this fetus out.
They just want it out. So we encounter them.
So they'll stop at nothing.
Yes. They'll come with their sticks. And of course, they have tried to do all sorts of things to see that the pregnancy comes out. But because they don't know what to do, they don't know what to use, they end up with those desperate measures to have it out. So they end up in hospital to have their issues sorted. We cannot take it lightly that actually people are having sex. Okay? People are having sex, and we cannot just rely on religion that it should be reserved for after marriage. No. Or after a certain age, maybe when they're 18, no. Young girls are having sex. I've personally seen a girl who was 12 years old. She came to hospital to deliver. That is a sign that actually girls are engaging in sex.
At 12 years?
12 years, at a very early stage. Okay. However, when it comes to abortion, it affects everyone.
Yeah.
Much as we see most of the complications in the young, that is between the ages of 15 and 19, we have also seen women, 35, 40, who come with abortion complications. For the case of Sarah Namono, the late, I don't think she was in the 20s, or she was in her teens.
I think from the story of the sister, she had some children before.
She has had about 4 children, but she's actually dying from a complication of an abortion. That means that all age groups are affected as long as the woman is within the reproductive age, that is between 14 years and 49. When they are still having their periods, they are able to get a pregnancy, which pregnancy can go either way, and they can suffer the complications. Okay. Yeah.
Wow.
So
basically, Doc, I'll come to you to really talk to us. There are those that come when they're in really very bad shape, largely because when they use crude abortion methods, they want to, keep it from their parents or from their spouses or what. So they sort of try out so many things, but they keep it internal and they don't come out to speak. And then it gets complicated. But also there are those that sometimes walk into medical facilities to ask for, a clinic abortion, and they're chased away because of the legal and policy framework. So I thought, perhaps before I can bring you, I just wanted to bring in Rose. Rose Wachikona is a lawyer and a human rights defender, and she's been in the subject of sexual reproductive health and rights for quite a while. She's worked with different organizations, including the Center for Health, Human Rights and Development, and to just sort of give us a legal perspective, surrounding Uganda's abortion laws. Here's Rose Wachikona.
Abortion is an issue in our country that is considered taboo by most, and many people prefer to stay away from it, considering it more of a women's issue. But our law has stepped in and it has legislated on this particular issue, which has made it difficult for women to access health services. And this has driven up the cost for post-abortion care, but also for accessing safe abortion services within our country. What our law says about abortion is, number one, in our constitution, where under Article 22(2), the constitution says that no one is authorized to terminate the life of an unborn child except as may be authorized by law. The challenge is that no law has been made since 1995 when our constitution was made. So we are operating in a lacuna. What exists is the Penal Code Act, which was passed in 1954 and is actually a preserve of the British colonialists who left it with us. And what it does is to provide criminal provisions that criminalize abortion and make it illegal within the country. They criminalize a woman who seeks an abortion. They criminalize a person who supports them to seek this abortion. And they also criminalize the supply of medicines that are needed to have an abortion, and also for post-abortion care. They impose a maximum of 7 years imprisonment if you're convicted of any of these offenses. But they do provide a defense where they say that a person who with skill and care conducts a surgical operation on a woman who is pregnant in order to help them have an abortion to preserve her life, then that person is exempted from this particular law. The challenge is that this law is very ambiguous. We have absolutely no explanation on what it means to preserve a woman's life. We have no explanation on who makes up a skilled person. What does it mean to be reasonable and to act in good faith? All this has absolutely no explanation. And what this has done, it has caused health workers to stay away from supporting women who need safe abortion services because they do not understand the law. They tried to explain this law within the 2006 guidelines and the 2012 guidelines on sexual reproductive health and rights, but these guidelines were abandoned by the Ministry of Health in 2018 when they were due to be passed and to be implemented within the country, majorly because they tackled the issue of abortion. This has caused a lot of confusion and ambiguity. And what we have seen in all our services is that health workers are being arrested. They are being arrested for providing post-abortion care, which is different from an induced abortion, because post-abortion care is all about providing care to a woman who has started the process and usually it has gone wrong. Maybe she's septic, she's bleeding, she's in bad shape. So a health worker comes in to intervene to provide the much needed care to save her life. But the police officers can't tell the difference between post-abortion care and an induced abortion, because usually the interventions between the two are the same. This year alone, we have supported over 6 health workers who have been arrested. They have suffered reputational cost. They have had to shut down their clinics. They have had to lose a lot of money, and some of them have even been convicted because of these ambiguous laws on abortion, yet they are providing post-abortion care. As a country, we need to do something to clarify the legal environment on abortion within the country, because very many women are suffering. We know for a fact that over 800 abortions happen every single day according to the Guttmacher report, which was released in 2017. We also know that over 22% of all teenagers within the country are sexually active, and that 8% of all maternal deaths are attributed towards unsafe abortion within the country. Until we clarify the legal environment on abortion within the country, we are going to continue suffering deaths and morbidities for women who have to turn to unsafe abortion because they can't get a safe abortion within this country.
Rose Wachikona there, who is a lawyer, human rights activist, and she previously worked with the Center for Health, Human Rights and Development, and of course she continues her advocacy against rude and shrewd legal and policy frameworks around this. Peter, clearly the Center for Health, Human Rights and Development has been at the center of pushing back on some of these laws, in fact, because we've been struggling at country level. You've taken this advocacy to regional level, even to the point of the East African Legislative Assembly, so that we can have the SRHR legal and policy framework, and so that it can be used as a point of reference to push back. But what has been your journey like, and your experience in dealing with this, especially on the legal front, Peter?
The question of abortion is a complex issue, and you'll notice that sometimes it's not just about the law. It also has religious and cultural connotations that are around it. But if we're dealing specifically with a legal framework, like Rose indicated, the biggest challenge we have is how the law is crafted. It is not clear, and that leaves it subject to abuse. When you're dealing with legislation that relates specifically to rights, a lot of times we place emphasis on the law being as clear as is possible. When a law that relates to human rights is not clear, then defending rights in as far as that law is concerned is very problematic. So those who are engaged in legislative drafting emphasize on making it as clear as possible.
Yeah.
And because
to
of
remove the ambiguity.
To remove any form of ambiguity in the law, so that it is executed as it is designed. But now with this law, you notice that there are lots of ambiguities. First of all, from the Constitution and then to the Penal Code itself. It keeps talking about issues that are not clear. And so, for most time, like Rose indicated, people never get to know the difference between post-abortion care and exactly what abortion is. And we have locally tried to advocate for amendment of this law. And unfortunately, at local level, the questions of our morality, the questions of our Christian beliefs come in to cloud that whole legislative reform processes. And the moment in this country you talk about abortion, you talk about sex, those are issues that are not supposed to be talked about. And unfortunately...
But there is evidence and data
now,
that speaks otherwise.
And that is exactly the problem, that in this country we've moved away from using data for policy making to using emotions and perceptions as a tool for decision making. And all these conversations you have about SRHR bill, including the East African Sexual and Reproductive Health bill, are all clouded in that. And you see, people who argue perceptions and beliefs do not usually have the burden of proving what they are saying. And now for you who is saying that, you see, there are challenges, no one is listening to the statistics. Statistics are very clear everywhere that things have really gone wrong. And if you talk, for example, to religious leaders, they will tell you, when you talk to them, the assumption you get is that young people are not actually having sex. But when you
that they shouldn't have sex.
They shouldn't be having sex.
It's abstinence, right?
One actually asked me, what business do young people have having sex? But statistics are showing us that 25% of young people are getting pregnant when they're teenagers. Okay? All the statistics that we have are not being used for policy making. So
I actually wanted to add, so the people here, at what time did you have sex? Your sexual debut? I think there is, it even comes down to that, because many of us here, I think we first had sex before we were 18, or maybe, I don't know about you, but yeah, it really speaks to, I mean, even when you ask those leaders, the MPs who always shy away from this conversation, many of them, I mean, there's statistics that shows the sexual debut in Uganda, it's at what, 12 or something?
Actually, the sexual debut for Uganda, for rural communities is just slightly above 16 years for rural. And then the ones for urban is about 17.4.
Yeah.
And that shows you that it is not that the people in town are actually, that the people in town are not having sex. And also when you do a comparison of pregnancies within urban and rural, you'll notice that the pregnancies in urban is low, but again, the teenage pregnancies in rural communities is actually high. And it is not that urban young people are not having sex. The only difference is that the urban young people are a little more informed about the sexual and reproductive health as compared to rural folks who actually do not have access to a lot of this information. And so that's what causes that deviation between the ones in town and those in the rural. So, and it helps you go to the argument of the need for that information, the need for information about abortion as provided for in the law. Actually, if you looked at the East Africa Sexual and Reproductive Health Bill, one of the things it was providing was for sexuality education for young people. And in its argument, it says that it is important to provide this because they will contribute to dealing with some of these challenges. If you go to young people and you ask them, what happens when you get pregnant? What happens when you need abortion services, for example? Under what circumstances do you have abortion? I will assure you that that information is not there. And that's why we end up with information that is within the peers that you have. And for a lot of times, the information within the peers is actually not correct information.
You're very right, because so, when these young people get pregnant and they're scared to tell their parents, they go to their peers, like you said, and their peers will lead them somewhere else.
Yes, and it's exactly what happened in this case of Sarah. A peer led her to another point.
Yes.
So in this country, the problem is not absence of information. Young people have a lot of information with them. What the challenge actually is access to the correct information. And unfortunately, our law does not allow for those conversations. Our cultures do not allow those conversations. So you continue to have a situation where young people rely on any information they come across. That's why when gynecologists tell you about young people coming with sticks and wires, it is from their peers. They think, okay, what do I do to resolve this problem? Because at that point, it is a question of life and death for them. You want to go back to school. You're thinking, my parent will just kill me when they get to know about this. So you listen to every opportunity to save the situation.
Yeah, that is
and
very
unfortunately, it is those moments that they go into desperate attempts and end up with the real trouble. That may cost them actually their whole future in terms of maybe even childbearing and all those things. So we need, as a country, to have honest conversations about abortion in this country, and we need to move away from perceptions and cultural and religious beliefs as a means of making policy decisions. We need to go back and look at what does the statistics actually say.
And you're right on this, but it's rather disturbing because we have members of parliament who, to the gallery, on the floor of parliament, will shout against it. When you put them over the side and say, look, do you know this is happening? Do you know young people are doing this? They say, man, I know, but my constituency, that will cost me an election. That will, I have had these conversations with them. I mean, you know, for example, our Minister of Health, who is a medical doctor, who, of course, in 2018 refused the guidelines to sign them. Until now, they are still there. These are people who understand numbers. They're people who, for example, if they were interested, they would call the different stakeholders on the floor and committee level, and they really consult strongly from, the scientists, the medical doctors, the people at community level, the church. I mean, get people to start having these very serious conversations, because listen, the more we run away from them and we hide ourselves under morality and run away from reality, we will continue losing people. And this was really very, very vividly seen when the legislators were discussing in the IALA that just closed. When legislators were discussing the sexual reproductive health bill, remember, it also has come through all back and forth, and there was a political connotation when they came to consult, because I think there's been several consultations within the East African community. When they came here, I think it happened in Munyonyo.
Yes.
There was a very, very big pushback from the minister, Sababu Turo, and all, different people who told them, the people who are now going in the house, that we will elect you if you will push back on the sexual reproductive health bill. So that there are those that, have gone to school, understand the numbers, and they seem to look away from the numbers and push for the morality, which is abstain until when you're married and you have sex.
You see, we are sustaining this populistic politics where we don't go into discussing the real problems, but we want to dance to the gallery and try to appease those who think the particular position is the correct one, instead of actually dealing with a problem. But for me, what gives me hope is that as long as these conversations happen, it will slowly begin to create a shift. And the position we are in, all these other European countries have gone through what we are going through. Even the British who brought the Penal Code Act, even the US, at one point, conversations around abortion was totally unacceptable.
Up to now, it's. I mean, you watch over international media.
It is a contested.
It's a contested issue all across the.
And so the beauty is that the more we have these conversations, and that's exactly I'm excited about these online engagements, because it provides spaces where the ordinary media would be uncomfortable to have a conversation on. And it is important that we honestly engage in this conversation. And I'll give you an example. When we started conversations on the EAC SRHR bill, when consultations went to Burundi, the whole house walked out.
I remember.
The whole house walked out because they could not afford to listen to a conversation about legislating about sex. When you put there sexual and reproductive health, I can assure you that if we had removed the word sexual and said science and something, these laws would pass. But in this country, when you talk about sex, there are words in this country you don't talk about, and sex is one of them. Abortion. When abortion is the other, people begin to think, hey, you want to legislate about people's sexual lives. But I can assure you that even while there's still contestation about some of these issues, what gives me hope is that people are now ready to go have a conversation on some of these issues. You say this, the other says the other. But previously, at some point, people would just walk out of this conversation. The parliament, the last consultations on EALA bill, on the EAC SRHR bill, happened in Burundi. While they had still contestation, at least they sat in the room and had this conversation.
Yeah.
Even in the consultation in Munyonyo, while the religious leaders made a strong choice, a strong argument against the bill, there were those who made a strong argument for the bill. And I'll tell you, you get shocked that even because a number of religious leaders now are beginning to argue and saying we need to have an honest conversation on these things. We are not going to keep our heads in the sand while people die and we say, no, you see, you're not supposed to be having sex, young people. So,
yeah.
And yet we are investing money in dealing with post-abortion care.
And that's the irony, because every single financial year, the Ministry of Finance allocates funding. In fact, Mulago Hospital puts in a request in their ministerial policy statement for the Ministry of Health, money that is supposed to go and treat post-abortion care, and perhaps that's where Entebbe Grade B, for example, gets money to treat these people who come with such complications.
Yes, and that's how dishonest we are as a people. That you say we there's no abortion happening, because that's the presumption we are creating. But then, unfortunately, you find we are allocating money to deal with post-abortion care. So that's a problem. When I was studying legislation, one of the things they would tell us in legal drafting class was that if you pass a law and you cannot convict someone under that law, then that shows you that law is not serving the purpose it was supposed to serve. And go across this country and look for any conviction on abortion. It is extremely difficult to find successful prosecution of abortion. And that shows you that the law in itself has challenges. A good law must be easily enforceable. But where you have a law that you cannot convict anyone on, and this is exactly the argument we gave people during the miniskirt law. You remember that it was called anti-what bill? the one for miniskirt bill. I remember that you're not supposed to. You have to dress in a certain. We actually told them, please have in law a law you can enforce. How many years down the road? How many people have we convicted on that law? Apart from creating that committee where the likes of Pastor Semper were sitting, drawing allowances, we've never convicted anyone under that law for indecent dressing and all those things. So, and that is exactly the problem, even with our law here.
All right, Peter, thanks. And I think Rwanda has had very progressive conversations around that. I know that during the consultations, President Paul Kagame has somewhat created that environment for people to speak, and they are really progressing.
Yes,
suffice to say.
Just to say on that one specifically, if you do a comparison, recently Rwanda did an expansion of their law on abortion. They also still have a restrictive law, but they have expanded the circumstances under which abortion can actually be done in Rwanda. And you see the results. If you look at indicators that relate to maternal mortality between Uganda and Rwanda, they're totally on the opposite. And you find that actually Rwanda, in terms of maternal mortality, is the model in East African community. It has just slightly over 200 deaths per 100 mothers who go into a public health facility.
Wow.
Here we are 300. If you go to South Sudan, it is 1,500. So the law plays a very important role in dealing with some of these deaths. If we had a fair law, the death that we are reporting now would substantially be dealt with. Because what pushes someone to go for unsafe abortion is the fact that they fear the law in the first place. How will I go to a public health facility?
Thanks a lot, Peter. I'll come to you. Thanks a lot. Interesting conversations. Here we are on the Sexual Reproductive Health and Rights podcast. My name is Solomon Serwanja, and with me I have Dr. Lukomwa David, who is an obstetrician, a gynecologist at the Entebbe Regional Referral Hospital, who is also a member of the Association of the Obstetricians and Gynecologists of Uganda, AUGO. I also have Peter Echeru, who is the programs coordinator for Advocacy at the Center for Health, Human Rights and Development. So let me just go back to Peter, to Dr. Lukomwa. Doctor, let's talk about the conversation of, if a young girl walked into Entebbe Grade B Hospital and they told you, I want to have an abortion, would you do it, and why?
It depends on the circumstances. There are many reasons why these women seek to have an abortion done. Okay. First of all, when a woman gets pregnant, there can be three options. It could be a planned pregnancy and it's wanted. It could be an unplanned pregnancy, but along the way, the woman gets to like their pregnancy and they will keep it. Then there's this class of people who will get an unplanned pregnancy and it is unwanted. And the moment they get such a pregnancy, unplanned, unwanted, they will want to terminate it by all means. By all means. So they have different reasons why they would want to terminate it. Some of them have been raped. Others it's as a result of incest. Others it's because of poverty. Okay? they will look at their situation. They think they cannot really support a baby, a pregnancy. Okay. Then others actually come in because of career. Yeah. There are many girls who come in because they want to go to UAE to do cheyo. Okay. They want the pregnancies terminated. Others it's because of school. Then there are those you get who think that, okay, who have had a very short interval between pregnancies. She has just had a cesarean section, 4 months down the road, she's pregnant again, and she will come wanting to have a pregnancy terminated. So when these mothers come, when they come seeking to have an abortion performed, we tend to sit them down. Okay, we tend to sit them down and go and try to discuss, one, the reasons why they want to have a pregnancy terminated. Okay, so you really you put them into a discussion, and of course when you sit them down, they'll open up and they tell you the reasons. Okay, like for the case of Sarah, domestic violence, lack of support, lack of information. You give them the information, tell them the good side of the abortion and the bad side. Okay.
But also Sarah's pregnancy was 5 months.
It was 5 months. Okay, 5 months. Very dangerous pregnancy. Very, very dangerous. Actually, the safe ones, those, if one realizes that maybe they are carrying a pregnancy they do not want and they don't wish to continue with it, why should you wait until 5 months? Okay. So the earlier you make the decision, the better. Okay. Yeah. So we try to actually counsel them and go through the levels of prevention. One, if you don't want to have an abortion done, why would you wait? Why would you wait to have an unplanned pregnancy, unwanted? So at least we counsel the girls, okay, not to get the unwanted pregnancies by using contraceptives, delaying sexual intercourse. Okay, yeah, that's why we actually advocate for contraceptive use. Okay, and I think that is the reason why they were also trying to bring in the use of contraceptives in girls in school. Okay, yeah. So that is like primary prevention. Secondary prevention, now she has gotten a pregnancy, she doesn't want it, she wants to terminate it. How can she do it? I would advise my fellow health workers, when you get such a patient or such a girl or a woman who wants to have a pregnancy terminated, by all means, we sit them down, counsel them. Some reasons are not really genuine reasons that they should terminate a pregnancy. You get a woman, she's married, okay? She's married, but because she has gotten a pregnancy 4 months down the road after a cesarean section, that doesn't mean that she should terminate the pregnancy. So when you counsel them and allay their fears, they tend to keep their pregnancies. So you look at the reasons why they want to terminate the pregnancy. When you counsel them, tell them that this and this can happen, we can help you here and here, they will keep the pregnancies. But then those who actually fail to keep the pregnancy and they want it out, we should really give them the right information, direct them, refer them to the people who we think can actually perform the abortion.
Who are those? Because they have come to you as a gynecologist, as an obstetrician.
When they come to
so you can't say you go to Dr. Serwanja. I mean, you're the expert here.
Yes.
So what you're basically telling me is I chase them away.
You don't chase them away. Honestly, we know that abortions are occurring. They're happening. There are girls who are getting pregnant without them wanting the pregnancies. And there are people in the community who are actually performing the abortions. Okay? So, among the health workers, there are those who are skilled to actually terminate a pregnancy. They have the skills and they have the equipment and they can do it safely. Okay? And actually, there are drugs on the market which can be used for pregnancy termination safely without a woman getting complications. However, among the health workers, not everyone can perform the procedure. So there are those who are so much tied onto the religion, others it's about the law. Okay, so there is need for values clarification and then attitude transformation for health workers. So there are those who are already transformed and they realize that if this woman comes seeking to have a pregnancy terminated, the mind is already disturbed. So if you chase her away, she'll only come back with the complication. So there are those who can actually offer the service. So if she comes and she has made up her mind, let us refer. Let us give them information and refer to the appropriate person. And when they come when they come with the complications, now that is post-abortion care, which is actually allowed.
And that's where you step in.
Yes, we step in. So we are allowed to give the emergency treatment. If she comes with severe pain because she has taken a very high dose of the drug to have a pregnancy terminated, let us help her remove the pain and maybe complete the pregnancy, and complete the abortion, because they can come with some product still in and they are causing a lot of pain, a lot of bleeding. All you have to do is remove the product and she'll be fine. If she comes with too much bleeding, we need to stop the bleeding. If she comes with the uterus that has been perforated or ruptured and she's bleeding,
you get it out.
Then we need to go in. If we can repair it, we repair. If we can't, then we get it out. If she comes with an infection, then we need to treat the infection. So we offer the emergency treatment. And on top of that, we also offer counseling on family planning, okay, such that she doesn't go into the same problem again. So we offer family planning counseling, and then we offer the service. Okay, that is if she really didn't want the pregnancy to come. So they will actually take on the family planning.
Okay.
And then we also do other things, link them up to other services like HIV testing and counseling and testing.
Okay.
Cervical cancer screening, provision of post-exposure prophylaxis, especially if they were raped. Okay, we can offer that.
Okay.
Yeah.
Thanks a lot, Dr. David Lukomwa. Let me come to you, Peter. Where do we go from here as we conclude this podcast? I wanted you to speak to people in charge of policy and the legislative framework. Where do we go from here? And what is SRHR planning to do in the next couple of weeks or months or years to push back on this?
I think we need to acknowledge one thing. And I have had people argue that no abortion, there are categories who argue that there's no safe abortion. But you get shocked if you look at statistics around the world. You'll get shocked that 76% of unsafe abortions happen in Africa. And that is substantially related to the fact that we have hugely restrictive legal frameworks. In situations where you have a fairly liberal legislative framework, you will consistently notice that actually people are able to access safe abortion, but also for those who have any other form of abortion that may not be induced, they can easily and quickly get to the health facility. The Ministry of Health in Uganda says that there are 3 major causes of mortality. One is delaying to
get to the health facility.
To reach the health facility. The other one is delaying to take a decision to actually go to a health facility. And then the other one is delay by a health worker to attend to the patient. Mm-hmm. Now, part of our problem is that because people fear the law and its implication, and then the moral questions, people take a decision to go to a health facility when the situation is so bad, even if it is just for post-abortion care. They eventually go when they are stinking, when they are now having pus and all that. That is when they go to a health facility. But now also when you get to a health facility, the doctor will start debating within himself to ask, what I am doing, am I safe? Mm-hmm. In case anything goes wrong.
In case I'm arrested.
Am I in the safe area? So all those delays.
That's why Dr. David was saying, I make a reference, and but he knows clearly he can do it, but he's scared of the law and is like,
yes.
But let me refer you to someone perhaps who has a strong heart to do it.
So there is that. Do I refer this person? Do I take a decision? So all that whole process, one from the person taking a decision to come to having a doctor attend to that person, is all around the legal framework. It all revolves around having in place a very restrictive legal framework. Yeah. So it is important that for policymakers, let's get back to evidence-based legislation.
Peter, there are worries from these policymakers, and I've spoken to many of them who say, once we open it up, we'll have very many abortions. We'll have very many girls going out there because, well, they'll have the sex. They know they can go and get abortions, so they think that the numbers will be many. That if you pass a law like that, you'll have so many abortions happening.
Actually, that is actually not true. And I will use, I'll give you an example. That at the height of when the Trump government passed the restrictive law, it's called what? The one which
Roe versus Wade.
No, the one that restricted funding to organizations that were providing this kind of services. And there's a study which was done specifically in Uganda, and they visited over 284 health facilities. And it demonstrated that there were organizations that were receiving US funding. They lost US funding because they refused to say, we will not provide the services anymore. Now, what happened is that when they did not provide those services, because now they didn't have funding, remember they had the nurses and all those that were being employed based on the United States funding. When they lost that, they also dropped the staff, and their ability to do outreach is also reduced. The statistics actually show that what happened was that the number of women seeking post-abortion care in public health facility increased by over 20% at that point, at health facilities where these NGOs that were providing this service were operating. So that shows you that there's a direct, that even if you illegal or you make it illegal, it has no implication, it has no correlation with reducing the number of people who are seeking abortion services. Because the thinking was that if you do not finance these organizations to provide, to go and provide to provide family planning methods, to support with the young people who are pregnant, that there would not be more cases of abortion. But the mere fact that public health facilities in those locations actually had an upward surge in the number of women seeking post-abortion care shows you that actually there was no change. And because women were not even able to access SRHR commodities, they were getting more unwanted pregnancies. And when women have unwanted pregnancies, those are the major targets for abortion. So they did not have access to family planning commodities, and so we saw a rise in abortions, and most of them were, of course, unsafe abortions, and ended up in the public health facilities to look for post-abortion care. So even if you put a law and say abortion will carry a death penalty,
people will still do it.
Abortion will happen. What we should do is to make a choice whether we want to choose people alive or dead. What exactly is it that we want?
Okay.
So it is important, the argument that when you open it, I've heard some people say people want to start using it as family planning method. That is not true.
Peter, where do we go from here as we conclude? Doc, I'm coming to you.
So I think it is important that conversations on safe and legal abortion continue in this country. And it should happen wherever it happens. I know a lot of main media are very hesitant to have these conversations, but we must have conversations on this, look at the data that we have, and be able to continuously engage decision makers, especially policy makers. I have interacted with medical doctors who understand this area, and they speak with authority on how it is possible to make it a little more safer. So it is important that we take lessons from countries that have made it liberal, like Rwanda, and see what exactly is it that they are doing. Are they making it, or are they turning abortion into a family planning method? Of course, certainly no. But then you're able to save lives. What is key is the right to health. That anyone who needs to go for a medical service must be given an opportunity to go for that, but should not be barred from seeking health services by virtue of the law that we have in place. So the law, the restrictiveness actually is violating people's ability to access health services. Wow. And so it is one thing we need to target. But to be able to change policy, we must be able to also have a change in attitudes, perceptions that we have in this community. Yeah. Once we do that, then it will be much easier to change the law. And that's why I think it's important. These conversations, we must not run away from them. We must sustain this conversation.
The conversations must happen. Yep. I can't agree more with you. Dr. David, where do we go from here? What can we do? What can the medical workers, actually, medical doctors before used never want to hear the word abortion anywhere. And I'm actually surprised that you even here talking about it. That means that these conversations are happening, just like Peter is saying, and that you are, being trained, you're being nurtured to understand the legal and policy framework, to understand how things are done. I'm happy to hear progressive people like you coming out to speak about these things. But Dr. David, where do we go from here as we conclude this discussion?
Yeah, thank you, Solomon. I think the most important thing here is to destigmatize abortion. Okay? Previously, we would look at whenever a patient came in hospital with an abortion, would think that they have actually done it criminally. We actually used to call it a criminal abortion. But actually, not all of them are induced abortions. Okay? So we should destigmatize abortion. Okay? And
Doctor, before you close that, a quick one. I have a friend who went to hospital and the baby came out, and then in the discharge they said she had an abortion. She was furious.
Yes.
At the doctor and said, "What are you saying?" Because the thinking is that for abortion to happen, it must be induced.
Actually, people don't want to listen to the word abortion. Okay? So we should destigmatize it, such that when someone gets a pregnancy termination, we take it normally. Okay? That this has happened, they need to have care. And the other thing is we shouldn't take abortion in only one perspective. Previously, when a woman comes to hospital with an abortion, we manage the medical bit, and that is it. However, we should look at it in all perspectives. Religion, in terms of culture, and then we put things together. So if a woman came seeking to have an abortion service, we shouldn't really take it in just one direction. Say religion doesn't allow this. Okay? We shouldn't take it maybe in terms of the law, that the law doesn't allow this. We should look at the circumstances and look at every woman who comes to hospital seeking the service as an individual. Sit her down and know the reasons why she wants to actually have a pregnancy terminated. That is the way we can actually have mothers safe. Okay? Those who really don't have substantial reasons, you can cancel them, they will keep their pregnancies and they will be safe. Those you think that the reason is substantial, that if I don't help this woman, you wouldn't really want a woman to move out of your face, goes for the unsafe method, and only comes back for you to remove her uterus. It is painful. So let us look at, and let us sit down the women and look at them as an individual, and then put all the perspectives together. If really it is to save her life, or to make her health better, be it psychologically, because I've seen some girls who come to hospital, they are in school, they are fearing to tell their parents, okay? So if you don't really help this girl, the next time she's going to come back, she'll be with a complication.
That is very true. Yeah.
So let us sit them down, look at her as an individual, look at the circumstances around, and then we find ways of helping them. And then lastly, for the health workers, post-abortion care is legal. It is allowed. And any health worker at any level can offer post-abortion care. Be it a midwife, be it a nurse, clinical officer, medical officer, gynecologist, they can offer post-abortion care. This can be done using drugs. A midwife can actually offer the drugs. If a woman comes with an incomplete abortion, she has products still inside, you can give the drugs and the products will come out and the woman will be okay. You can manage the infection. If she comes with an infection, you can manage. It is only when it requires a surgical procedure, maybe laparotomy, maybe an evacuation, that's when you need maybe a gynecologist to come in. But you can offer help at any level. So any health worker can offer post-abortion care. They can counsel for family planning. They can refer. So it is legal. They should be able to offer the service.
Dr. David Lukomwa, obstetrician gynecologist at the Entebbe Regional Referral Hospital. He's also the member of the Association of Obstetricians and Gynecologists of Uganda. Thank you so much for being on this podcast. Much appreciated, and it was quite great hearing from you.
It's a pleasure.
Peter Echeru, Programs Coordinator for Advocacy at the Center for Health, Human Rights and Development. Thank you so much for sharing your views.
You're welcome.
Thank you all for listening to the first episode of the Sexual Reproductive Health and Rights podcast in proud partnership with the Center for Health, Human Rights and Development. My name is Solomon Serwanja. Look out for our next episode about sexual reproductive health and rights. Let's see what we'll be having next. From all of us here, thank you for listening.